1, 2,
And maybe 70-year-old female receiving liposuction.
Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
Let's start with
300, please.
I'll keep your again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what do the ECMO people check? And her blood pressure is off the properly.
45 minutes of CPR and no return of circulation. Okay.
Imagine you're watching a weather radar, right? And you see this dark red band of a severe storm just rolling in. You don't wait for the rain to literally start pouring inside your living room before you close the windows.
Right, obviously not.
So in psychiatric nursing, when you have a patient who's pacing the hallway, clenched fists, breathing really heavily, I mean, that is your dark red band. You absolutely do not wait for a chair to be thrown.
Exactly.
Today, we are mastering the exact protocols you need to secure the environment before that storm makes landfall.
Yeah, and we're stepping in as your elite psychiatric nursing educators for this deep dive.
Yeah.
Our mission here is, well, to apply the 80-20 rule to the definitive manual on managing hostility and aggression.
Because, let's be real, you don't need to memorize every single word of the textbook to pass the NCLEX, right? Or to keep your unit safe.
No, definitely not. You really just need the 20% of the concepts that give you 80% of your clinical judgment, spotting the escalation early, prioritizing safety, and, mastering the pharmacology protocols you're actually going to use in a crisis.
Okay, let's unpack this, because before we get to the medications and the physical restraints and all that, we really have to establish baseline definitions. In everyday conversation, we use words like anger, hostility, and aggression basically interchangeably.
Oh, yeah, all the time. But clinically, treating them as the same thing is a very dangerous error.
Right.
They represent entirely different stages of a behavioral continuum.
Right. So, break that down for us. What is the actual difference?
Well, anger itself is not a pathology. It's a normal physiological survival response to frustration or fear. When a patient feels threatened, their sympathetic nervous system kicks in. The whole fight or flight response.
Heart rate goes up, muscles tense up.
Exactly. And if that patient uses assertive communication, saying something like, I feel frustrated because I don't understand my discharge plan, that anger is actually a productive tool for problem solving.
But when that anger bypasses healthy communication and turns into an attempt to, intimidate, we cross into hostility. Verbal abuse, threatening gestures, refusing to follow unit rules.
Right, is verbal aggression.
Yeah.
It seems like the patient uses hostility to manufacture a sense of power when they feel internally powerless. That is the core psychological driver.
And if we fail to de-escalate that verbal hostility,
then it crosses the ultimate boundary into physical aggression, which is an actual physical attack on a person or the destruction of property.
So to understand why a patient makes that leap, we really have to look at the neurochemistry, right?
Yeah, we do. Serotonin operates as the brain's braking system. It heavily inhibits aggressive impulses. So low serotonin is a major biological risk factor for violence.
So the brakes are failing.
At the exact same time, you often have heightened activity of dopamine and norepinephrine, which those fuel impulsivity and reactivity. So the brakes are gone and the foot is pressed hard on the gas pedal.
Wow. And if that patient also happens to have, say, a traumatic brain injury or dementia that has physically damaged the limbic system or the frontal lobes,
then their actual steering wheel is broken. They no longer possess the neurological hardware required to modulate those aggressive impulses.
If the internal steering wheel is broken, it makes perfect sense that the nurse essentially has to step in and act as their external steering wheel.
Exactly.
And I want to test my clinical instinct here. If I have a patient whose dopamine is surging, right, and they are visibly furious, my gut reaction is to let them burn off that energy, give them a punching bag, tell them to scream into a pillow, let them get it out of their system so they don't redirect it at another patient.
See, that is one of the most common distractors you will see on nursing exams. And in practice, it is a massive trap.
Wait, really?
Yeah. What you were describing is the concept of catharsis. For a genuinely angry, escalating patient, catharsis is strictly contraindicated.
Wait, letting them hit a punching bag is contraindicated?
Hitting a punching bag or screaming violently actually reinforces the neural pathways of physical aggression. You are literally teaching the brain that physical violence is the correct physiological release for frustration.
Oh, wow, I never thought of it that way.
Yeah, the clinical data shows it often increases angry feelings rather than resolving them.
So what do we do instead?
The highest yield nursing intervention is to redirect that physiological energy into a safe, non-aggressive, repetitive motion.
Like having them walk the halls with you.
Exactly. Going for a brisk walk burns off the adrenaline from the fight or flight response without, reinforcing a violent behavioral loop. And you pair that physical pacing with teaching assertive communication. You prompt them to use I statements.
So we guide the energy, we don't just let them explode, but how do we predict who is most likely to escalate? Like if we are doing our initial shift assessments, we need to know who is at the highest risk for violence.
The single best predictor of future aggression is a documented history of violent behavior or arrests. That is your ultimate clinical red flag.
History always repeats itself. What about other factors?
Secondary high-risk factors include active substance use, which obviously lowers inhibition, a history of trauma, which primes the nervous system for a constant state of threat, and command hallucinations.
Command hallucinations are terrifying to manage. I mean, the patient is hearing a voice explicitly commanding them to hurt themselves or someone else. Yeah. And that ties directly into how aggression manifests across different psychiatric disorders. With schizophrenia, the violence is almost always driven by paranoia or those command hallucinations.
Yeah, they aren't acting out of malice. In their altered reality, they genuinely believe they are fighting for their life.
Contrast that with how aggression appears in severe major depressive disorder. You don't typically associate depression with violence.
No, you don't. But the text outlines this phenomenon called anger attacks. These are sudden, intense spells of rage where a depressed patient feels emotionally trapped or just totally overwhelmed.
So how does that differ from other types of aggression?
The key differential here is that these attacks rarely involve physical violence toward others, and they're almost always followed by deep, crushing remorse.
That sounds incredibly similar to the presentation of intermittent explosive disorder, or IED, though the sources clarify IED is a really rare diagnosis.
Yeah, it's typically seen in adult males.
Yeah.
They have these violent, explosive outbursts over microscopic provocations.
Like someone bumping their shoulder in the hallway.
Exactly.
Yeah.
It is grossly disproportionate to the trigger. But just like the depression anger attacks, the explosion is followed by heavy remorse and embarrassment.
It's so interesting, and how a patient processes and expresses that underlying anger is heavily influenced by their environment and their culture too.
Oh, absolutely. Culturally competent care requires understanding these variations, which is why the text highlights several specific cultural syndromes.
The mechanics behind those syndromes are fascinating. Take Hwabyung in Korea, which translates to fire illness. It is predominantly seen in females who have suppressed their anger for years due to strict societal or patriarchal norms.
Right, because that physiological stress response has nowhere to go. It rewires the body to express the anger somatically.
Yeah. The patient presents with severe abdominal pain, insomnia, a sensation of a mass in the chest. A Western nurse might just label it a somatization disorder and completely miss that suppressed anger is the root pathology.
And on the other end of the spectrum, you have explosive cultural syndromes. Buffet délirant, observed in West Africa and Haiti, involves sudden outbursts of agitated, aggressive behavior accompanied by confusion and hallucinations.
It mimics a brief psychotic episode, right?
Yes, but it is deeply tied to cultural expressions of acute stress.
Then there is emok, seen primarily in Southeast Asia. It's a dissociative episode occurring exclusively in males. It starts with a period of silent, intense brooding after a perceived insult, which suddenly just detonates into violent, homicidal behavior.
The brain essentially short-circuits under the weight of the social shame. It's a stark reminder that if we ignore the underlying pressure, the explosion is inevitable.
Which brings us to the core of nursing practice. Understanding the cultural and neurochemical roots of aggression is vital, but when you are standing on the unit, you need a systemic method to manage the escalation.
You have to treat behavioral escalation the exact same way you treat sepsis.
A localized infection that spreads if you don't jump on it early.
Exactly that. The 5-phase aggression cycle is your clinical protocol for preventing systemic failure. Phase 1 is the triggering phase. The infection is localized, the patient is restless, pacing, breathing rapidly, muscle tension is increasing.
Now, if I see a patient in phase 1, my instinct is to sit them down and deeply reason with them. Try to unpack the psychological root of whatever triggered them so we can fix it.
Attempting complex psychological processing during phase 1 will often accelerate the escalation.
Wait, really? So no deep therapy sessions right then?
No, absolutely not. Their sympathetic nervous system is highly activated. Their frontal lobe is already losing its grip on logic. The first nursing intervention must be empathy delivered through short, simple statements. You do not overcomplicate things.
Got it. Keep it simple.
You maintain a safe physical distance, suggest moving to a quiet area to decrease sensory stimulation, and this is the critical moment to offer PRN or as-needed oral medications. You want to extinguish the spark before the fire spreads.
But if they refuse the PRNs or the sensory environment is just too chaotic, the localized issue goes systemic. We hit phase 2, escalation, the physical changes become dramatic.
Very dramatic. Flushed face, swearing, demanding, clenched fists. Their ability to think clearly is just gone.
So what changes for the nurse in this phase?
The clinical dynamic completely shifts here. In phase 1, the nurse was offering options and choices. In phase 2, the nurse must assume executive control of the situation. You provide firm, direct commands. You order a timeout in their room.
And this is when the show of force is initiated. The primary nurse summons assistants, and you suddenly have 4 to 6 staff members arrive. I initially thought a show of force sounded really confrontational, like we're daring the patient to act out.
It relies entirely on the psychology of visual deterrence. The backup staff do not crowd the patient. They stay further back than the primary nurse, who continues to communicate calmly but firmly.
So they're just visible, not closing in.
Right. The visible presence of a highly organized team sends a non-verbal message. Quote, "Your internal steering wheel is broken. We have enough people here to safely act as your external steering wheel. We will not let you hurt yourself or anyone else."
And does that actually work?
Very often, yes. The sheer visual evidence that violence will not be successful convinces the patient to take the IM medication and step into the timeout.
But sometimes the pathology is just too severe, the infection goes completely systemic, and we enter phase 3, crisis. The patient loses all behavioral control. Hitting, biting, throwing heavy objects. Verbal de-escalation is officially useless here, right?
Totally useless. The singular priority in phase 3 is safety. This is when the facility's strict protocols for seclusion or physical restraints are initiated. It is highly orchestrated clinical immobilization.
The logistics outlined in the text are incredibly specific. You need 4 to 6 trained staff members. You assign one specific person to control each individual limb to prevent unequal torque and potential fractures.
Yeah, you have to be so careful.
You need one staff member dedicated entirely to protecting the patient's head to prevent biting and head banging, and another to control the torso if necessary. It isn't just a dog pile in the hallway, it's a medical procedure.
Exactly. And while the team safely immobilizes the patient, another nurse is obtaining the primary provider's order, which is legally required immediately, and preparing the emergency intramuscular medications.
And once those IM meds take effect, the central nervous system depression begins. The muscle tension drops, the aggressive thrashing stops, and we transition into phase 4, recovery.
At this point, they are regaining control. The therapeutic response here is to help them relax. Once they are cognitively present again, you can finally do what you wanted to do in phase 1. Explore the trigger.
Okay, now we can talk.
Right. You ask, what can we do differently next time you feel that way? You also have to debrief with the staff to evaluate what worked and what didn't.
That staff debriefing is crucial for unit safety. And once the patient is ready, you carefully reintegrate them into the unit milieu. This is phase 5, post-crisis. They're back to their baseline. Often they are crying or expressing intense shame about what they just did.
And the text highlights a massive, non-negotiable rule for phase 5. Do not lecture or chastise the patient.
It makes perfect sense now. If their aggression was driven by a neurochemical failure, like a lack of serotonin or a dopamine surge, lecturing them is like yelling at a diabetic patient for having low blood sugar.
That's a great analogy. It destroys the therapeutic rapport and ignores the medical reality of what just happened. You discuss the event calmly, providing objective feedback that you expect them to handle feelings safely moving forward, but you do not shame them.
Let's loop back to the pharmacology we used during that crisis. Because understanding the mechanism of action for those IM injections is a massive part of safe practice. When a patient is actively throwing chairs in phase 3, what are we actually putting in the syringe?
The gold standard acute combination is haloperidol and lorazepam.
Okay, Haldol and Etifon.
Right. Haloperidol is a high-potency conventional antipsychotic. It rapidly blocks dopamine receptors in the brain, essentially pulling the patient's foot off the neurochemical gas pedal, which reduces acute agitation and psychotic symptoms.
And lorazepam is a benzodiazepine. It enhances GABA, which is the primary inhibitory neurotransmitter in the brain. It sedates the central nervous system.
Typically, we are giving 2 milligrams every 45 to 60 minutes until the severe agitation breaks.
But looking at the text, I found a really jarring contradiction. If lorazepam calms the nervous system, why does the manual explicitly warn that benzodiazepines can sometimes increase aggression?
This is where patient profiling dictates your pharmacology. Benzodiazepines are highly effective for reducing agitation in older adults with dementia or patients experiencing severe anxiety.
Okay.
But if you give a benzo to an aggressive patient with a personality disorder or someone who is not actively psychotic, you risk a paradoxical reaction.
A paradoxical reaction, meaning the drug achieves the exact opposite of its intended therapeutic effect.
Also, you right in a kick. Think about what happens when someone drinks too much alcohol. Alcohol acts on the same GABA receptors as benzodiazepines. It depresses the central nervous system, starting with the frontal lobe, which governs social inhibition and impulse control.
Right, people get sloppy.
If the only thing stopping a highly agitated, non-psychotic patient from punching a wall is their fragile frontal lobe filter, and you chemically depress that filter with lorazepam.
You've just given them liquid courage, you remove the last remaining brake pad. That completely changes how you approach the medication order based on their underlying diagnosis.
It requires sharp clinical judgment. And the medication strategies shift entirely when we move from acute crisis management to long-term maintenance.
Like what?
Well, the text points to lithium for aggression, tied to bipolar disorder and conduct disorders, but it also highlights carbamazepine and valproate, which are anticonvulsants, for managing aggression in dementia, psychosis, and personality disorders.
I noticed that. Why are we giving anticonvulsant seizure medications to a dementia patient who doesn't have a seizure disorder?
Because anticonvulsants work by stabilizing the electrical gradients across neural membranes. In a seizure disorder, they prevent localized electrical misfires from spreading across the brain. In an aggressive psychiatric patient, they achieve a similar stabilization, preventing minor emotional triggers from cascading into massive, explosive behavioral misfires. They act as mood stabilizers.
That makes total sense. The manual also lists atypical antipsychotics like clozapine, risperidone, and olanzapine as highly effective for long-term aggression management, especially in brain injury or dementia patients.
Yeah, they are very common.
But regardless of whether you are giving an atypical antipsychotic or an acute dose of haloperidol, there is a major safety red flag nurses have to monitor for.
Yes. Anytime you are altering dopamine levels with antipsychotics, you must monitor for extrapyramidal side effects, or EPS. These are severe, sometimes irreversible movement disorders, muscle rigidity, severe tremors, acute dystonic spasms of the neck or eyes. It is incredibly distressing for the patient.
And the NCLEX memory trick the sources provide for treating EPS rapidly is administering benztropine, also known by the brand name Cogentin. It restores the balance between dopamine and acetylcholine in the brain.
Absolutely. So we have the neurochemistry, the cultural factors, the 5 phases in the pharmacology. But we cannot ignore the physical environment itself. The therapeutic milieu, the social and physical atmosphere of the psychiatric unit dictates how often these crises even occur.
A striking point in the manual is that a lack of psychological space triggers aggression much faster than a lack of physical space.
Right. Psychological space refers to autonomy, privacy, and predictability. If the unit schedule is chaotic, if therapy groups are randomly canceled, if patients feel their concerns are ignored by the staff, the baseline tension of the entire milieu rises. It creates an environment primed for phase 1 triggers.
And when you are interacting with a patient who is escalating within that milieu, their physical space requirements radically alter. The text states that potentially violent people have a perceived body space zone up to 4 times larger than the average person.
4 times larger. Clinically, that means if you stand at a standard conversational distance from a patient in phase 2 escalation, their amygdala interprets your physical presence as a direct, imminent threat.
Just standing there can escalate them.
Your proximity alone can push them into phase 3. The nursing rule of thumb is to remain significantly further back, keep your hands visible, and never position yourself between the patient and the door. You never want them to feel cornered.
The hospital environment isn't just a pressure cooker for the patients, though. The sources spend significant time addressing the toll this environment takes on the clinicians. We have to talk about workplace bullying, or lateral violence.
It's a huge issue.
The Joint Commission, JCAAO, has issued sentinel event alerts regarding intimidating and disruptive behaviors among healthcare providers.
Lateral violence is a systemic infection in healthcare. It encompasses experienced staff belittling new nurses, physicians refusing to answer pages, condescending language, and blatant power tripping.
It destroys the culture of safety.
Completely. When nurses are afraid to ask questions or call for backup because they fear ridicule from their colleagues, medical errors skyrocket and staff burnout accelerates.
When you combine the psychological weight of lateral violence with the physical danger of patient assaults, the job becomes unsustainable. But the sources do provide concrete interventions. They highlight behavioral skills training, or BST, where staff physically practice and role-play managing violent situations, building muscle memory for crisis response.
They also spotlight the ASP program, that's the Assaulted Staff Action Program. ASAP was created to provide immediate psychological first aid and peer support to staff members who have been assaulted by patients.
I think the manual said they've responded to over 10,000 incidents.
Yeah, over 10,000. It is a powerful acknowledgement that trauma-informed care cannot exclusively be directed at the patients. The institution has a mandate to protect the psychological safety of its clinicians as well.
Okay, let's distill this down to the absolute highest yield 20%. First, catharsis is a distractor, so assertive communication and safe physical pacing are the priority interventions.
Right.
Second, the single best predictor of future violence is a history of past violence. Third, you must use the 5-phase aggression cycle to match your intervention to the severity of the symptoms.
So empathy in phase 1, a visual show of force in phase 2, and highly coordinated physical restraints and IM medications in phase 3.
And finally, understand your pharmacology mechanisms, particularly the risk of paradoxical reactions with benzodiazepines.
And as you take these clinical protocols into practice, consider the fundamental tension at the heart of psychiatric nursing. The literature mandates that every patient possesses a fundamental right to the least restrictive environment possible.
Yes, that's a core legal and ethical principle.
Yet we know an escalating patient's perceived body space quadruples, and unit safety demands immediate, rigid protocols.
It's a daily high-wire act.
It really is.
Yeah.
When you are standing in that hallway observing a patient slip from phase 1 into phase 2, you have to determine exactly where the line exists between maintaining a therapeutic, empathetic boundary and enforcing an institutional restraint. How do you balance your ultimate duty to protect the physical safety of the ward with your ethical duty to protect the patient's individual autonomy? It is a complex clinical judgment you will have to refine every single shift.
You are watching the weather radar, seeing the storm approach, and deciding the precise moment to board up the windows without needlessly locking the person inside. Thank you for joining us on this deep dive. Keep trusting your clinical instincts, keep questioning the underlying mechanisms, and we will catch you next time.